I'm Annette Ozaltin, a Program Director at Results for Development, R4D, and I'm pleased to present part 2 of the findings from the campaign financing landscape analysis that we conducted for the Health Campaign Effectiveness Coalition. I encourage you to watch part 1 first, but I'll give you some brief context up front just in case you haven't managed to. In part 1, I described the growth of disease-specific financing over the last 25 years, which has driven a proliferation of standalone campaigns with little coordination between them or between health programs or partners. I also described a growing momentum for integration, which is emphasized in global strategy and guidance across the 5 different health areas: polio, immunization, malaria, NTDs, and within nutrition, vitamin A supplementation. I also mentioned that despite this growing interest and support from global strategy, integration efforts and coordination across programs and partners remain limited. And this conundrum, in part, inspired this financing landscape analysis. So the leadership team of the Health Campaign Effectiveness Coalition prioritized identifying the financial barriers, bottlenecks, and bureaucratic obstacles to integration or coordination between health programs and across campaigns, to identify the disincentives at the global and country level that hinder integration of campaign components or functions or co-delivery of interventions. But the aim was not only to shine a light on the financial barriers and disincentives, but to surface opportunities to overcome the barriers, address disincentives, and strengthen cross-campaign collaboration and integration with health systems. The landscaping exercise was a rapid qualitative exercise. We conducted 51 semi-structured interviews with key informants representing funding institutions, implementing partners, and country programs, all across the 5 disease-specific areas. We also captured the broader health systems and health financing perspective and just focused the analysis primarily on settings with many externally financed campaigns. So keep that in mind as you hear about the opportunities in the upcoming slides. The barriers and disincentives we surfaced are organized into 7 main themes, which I discuss in greater detail in part 1 of the presentation, but generally relate to fragmented financing with different financing mechanisms, disjointed planning, and high transaction costs for programs to manage this complexity. And at the same time, no one feels any negative consequences of not integrating or coordinating. And in settings with primarily externally financed campaigns, the government and health programs do not have an incentive for integration. And in fact, there are powerful disincentives as well. After surfacing a long list of barriers and disincentives, one could feel discouraged. However, the key informants we spoke with shared a huge number of opportunities to address these challenges. So our opportunity space is organized into 3 main themes. First, around collaborating, co-investing, and learning in specific geographies. The second, around advocacy and coordination. And the third, around research, guidance, and tools. And for the entire set of opportunities, I think there is something unique in this moment, perhaps even for those ideas that have been tried before. And the HCE Coalition, this platform across the 5 disease-specific areas, is really unique. And with the growing global interest and momentum, the recovery efforts after the pandemic, there's really a lot of opportunity here to make some progress. The first theme is around collaborating, co-investing, and learning in specific geographies. And it has 3 sub-themes. And the first is around aligning and coordinating funding. This is illustrated by the quote on the right. If it is the money, then you have to allocate the money in such a way to make people play together. And throughout this presentation, you'll see some quote bubbles that we pulled from the interviews. This was the #1 opportunity shared in the interviews, and also aligns with the recent Lancet Global Health Commission on Financing Primary Healthcare, which calls for a need to bring coherence and efficiency to the combination or articulation of existing financing mechanisms. It encourages donors to avoid creating parallel funding systems, and it calls for agencies to immediately change approaches to providing financial and technical assistance to reduce fragmentation. So one of the first means to do this could include establishing cost-sharing arrangements, what some call pooled financing mechanisms, that government or partners could access to support coordination between programs, integrated planning, and joint interventions, joint campaign interventions, either functions and or co-delivery. It could also include aligning planning and grant cycles across funders in countries where the timing is amenable. There could be a real opportunity here with the beginning of the Global Fund grant cycle, for example, and countries beginning their full portfolio planning, the FPP processes for Gavi. Another opportunity is around creating a common platform for increased visibility and harmonization of payment rates among donors and implementing partners. So this could be around per diems specifically, or other costs as well. And the idea here is that there would be greater financial alignment and increased budget and fiduciary transparency. There's also potentially an opportunity in the agenda of the Sustainable Financing for Health Accelerator and PHC Accelerator as well. Gavi, the Global Fund, and the Global Financing Facility, GFF, they're all co-leads, and they meet regularly to discuss how to improve alignment and joint approaches at the country, regional, and global levels. So having a campaign agenda item could be interesting to pursue. The next sub-theme on collaborating, co-investing, and learning in specific geographies is on optimizing incentive arrangements to encourage campaign integration and coordination. And this is illustrated by the quote on the right, which says, "My country has been implementing integrated SIAs, campaigns, over the last couple of years. My observation is that integration is easier when there is a financial incentive to integrate." So there were a number of different types of incentives that were shared as an opportunity here, and they ranged in terms of targeting the national program, the facility, or the individual level, and would really depend on country context. But it could include adjusting payment rates for frontline providers. This was an open question discussed by quite a few people on how we address the unintended consequences of integration, which may mean fewer standalone campaigns and a loss of income to frontline workers. So an upward adjustment in rates may be warranted as they take on additional responsibilities. And so this was an opportunity mentioned by quite a few people. Another option would be to leverage a variety of results-based financing incentives to encourage integration. They could range from performance-based financing, and contracts specifically could look at disbursement-linked indicators, results-based budgeting, and direct facility financing. These are being tried in a lot of different settings with some great lessons to share. And so the idea would be then that a specific country context would determine what would be the right mix of incentives that would be encouraging integration or coordination. A third option would be to permit the government to retain any cost savings from integrated campaigns. So they would receive the full allocation for standalone campaigns that they would then be able to reprogram for the system. This next sub-theme is around functional integration. And this would include investment in joint health system functions and tools across campaigns of different health interventions or antigens. with an aim of supporting coordination and addressing inefficiencies related to duplications or misalignments across functions. This could include functions like data collection, analysis, and information sharing, for example, population and household enumeration data. It could also include functions like micro-planning, health worker training, whole sort of range of digital tools and solutions, and campaign monitoring, evaluation, and learning systems. This would have the added benefit of strengthening primary healthcare systems alongside campaigns as well. Another idea is to broaden out COVID-19 infrastructure or functions, investments in infrastructure, investments in functions to address other antigens and interventions. And this was shared in the context of many funders investing in new infrastructure for COVID-19 vaccine distribution, for example. So the second theme is on advocacy and coordination. And the first major opportunity is to establish or strengthen existing global and regional platforms for setting the agenda on integration, for engaging in advocacy efforts, for coordinating among partners, and then monitoring and measuring success. This could include a global measles and polio working group that would be responsible for managing a shared vaccination plan and calendar. And it could also include collaboration on multi-antigen campaigns. And this could be through the existing IA 2030 disease-specific working group. In addition, greater leadership at the global level was called for from a number of key informants we spoke with, and particularly recognizing the WHO's role in agenda setting, which could even include convening member states on health system strengthening and integration, perhaps as part of a SDG summit. And greater leadership was also asked of Gavi, Global Fund, WHO, and UNICEF on this agenda particularly, collaborating on integrated campaign planning and establishing regular coordinating mechanisms amongst the partners. The quote on the right illustrates this gap in global platforms. It says, "There's no global platform, no global forum to talk about these things. There's no platform for this to be discussed. If everyone wants it in IA 2030, and UNICEF wants it, and Gavi, and Global Fund, and WHO, why is there not a platform? Get the right people around the table or on the screen. That would push the discussion forward." Next, at the regional level, there is opportunity for leadership on integration through political and technical bodies. First, from WHO Afro, being co-located across the programs in Brazzaville, and a role really in how to engage countries on campaign integration. And leadership from a more political forum was also suggested, with Africa Union and Africa CDC bringing programs and partners together on campaign integration, which could also include setting up task forces and potentially even funds, for example, on NTDs. Another opportunity was to involve the African Leaders Malaria Alliance, ALMA, which could include inclusion of campaign integration indicators in their scorecard. Continuing with the advocacy and coordination theme at the country level, there was a strong recommendation for a funded campaign integration working group that would be responsible for facilitating joint planning, promoting integration, and fostering intersectoral collaboration. And this aligns with several global strategy documents, including WHO's forthcoming guidance that's called Considerations for Planning Integrated Campaigns, Immunization and Beyond. A single NTD platform was also recommended for the preventive chemotherapy NTDs, and specifically a 5-year plan for campaign integration, and really focusing that at the country level, ideally synchronized with the Global Fund cycle, Gavi full portfolio planning, the NTD master plan, and so on. Another major opportunity was to designate focal points to identify opportunities and drive integration and coordination. So first, within major campaign funding institutions and implementing partners, and also within government, ideally a funded high-level position situated outside the programs responsible for coordination and planning. And the quote on the right illustrates this need for designated focal points. Even though integration is identified as a strategy, there's nobody assigned to it in any of the key programs. If you have nobody assigned to looking for opportunities and for making sure that we get the applications, there's nobody to make sure that we're taking advantage of every opportunity. With nobody in charge, nothing really happens. And finally, the last theme is on research, guidance, and tools. Opportunity exists to synthesize existing evidence. For example, systematic reviews on the questions of inquiry for this financing landscape analysis, on the impact of integration on effectiveness, equity, and efficiency, looking across the 5 disease-specific areas. And also on child health days and MNCH weeks to understand where those delivery strategies have been successful and where they have been discontinued and why. Documentation of lessons learned was also recommended on integration lessons from key global initiatives, such as the maternal and neonatal tetanus elimination initiative, and also on polio elimination, and also documentation of lessons on country-led integration efforts and health system reform. And finally, documentation from country coordinating platforms for health financing and donor alignment. And these latter 2 would be particularly relevant for the pooled funding and integrated campaign working group opportunities. There were also a number of recommendations for new evidence. For example, the WHO is leading these efforts, cross-programmatic efficiency analyses, CPE analyses, with the aim of identifying areas of inefficiency across different functions, and inclusion of campaigns was identified as an opportunity for these CPE analyses. Another idea was to map different campaign functions and funding flow analyses in specific countries. And new evidence was also recommended on the use of campaign funds, looking at expenditure tracking and costing exercises. And lastly, modeling exercises to estimate the externalities of integration. There were also a number of opportunities shared for global guidance and tools, and for country policies and plans. First, WHO guidance on antigens and interventions that can be integrated or co-delivered, and particularly looking for guidance on the safety and efficacy of co-administration, particularly for the NTDs. Another opportunity for WHO to require that campaign data be reported on a single template for different diseases. Additionally, a guiding principles or checklist for campaign funders, which would specify how investments can both do no harm and include mechanisms to strengthen primary healthcare. Cross-cutting campaign digital and planning tools, and a tool to support countries in budgeting for integrated campaigns. On country policies and plans, a role for the regional and country offices of UNICEF and WHO in particular was identified as important in working with governments towards institutionalization of integration or coordination. And this could be through working on operational guidelines on the health interventions and campaign functions that warrant integration or coordination for a specific country. It could be through working to develop national health policies that encourage integration of campaigns. And it could be to work on national health sector plans that focus on campaign integration as well. So from this long menu of opportunities, the HCE Coalition is now developing an action plan related to each of the 3 themes and is focused on the long-term problem rather than just short-term solutions, as illustrated by the quote on the right. Do we need to open Pandora's box? We can come up with some short-term solutions and figure out how campaign A and B can be integrated, or the next campaign in 2023. But that doesn't solve the longer-term problem. At some point, we really need to have these difficult conversations about governance and financing. So the HCE Coalition will be sure to share more later this year about the actions it will be taking to overcome the barriers, address disincentives, and strengthen cross-campaign collaboration and integration with health systems. And finally, I'd just like to express my gratitude to the many interviewees that shared their time and brilliance to inform this analysis, and to recognize the broader team at R4D that contributed, and particularly Edward Owino. Thank you.